That's a good question. So just to summarize, just so everyone hears that, the question is, it's a situation where we're trying to find the focus, where exactly the seizures are coming from, and we're having a tough time finding it. The tests don't seem to reveal anything, and one of the questions was, having a VNS, are you not able to get 3 Tesla MRI? So this is very hospital dependent. Different hospitals set their own policy as to whether or not it's safe, and it particularly has to do with a special coil that they require to put the patient in. And depending on the details, how much of the wire is left and so on. So for that question, I can talk to you afterwards. It's a very specific scenario, and we can talk about there's certain hospitals may be able to do that depending on if they have the a proper coil. Yes. Generally, yeah. Generally, the standard MRI that we require for epilepsy evaluations is a 3 Tesla MRI, and it's not just any specific sequences that are very important. For example, looking at certain structures in the temporal lobe, which are very common in seizure, especially in adulthood. So yeah, it's a very specific sequence they require. No problem. Other questions? I can speak a little bit more about, yeah, go ahead. Yeah, go ahead. Yeah. It's the strength of the magnet. So a 3 Tesla magnet is a much stronger magnet than the standard 1.5 Tesla. And also the so for epilepsy, one of the greatest challenge is finding where exactly the seizure is coming from. Sometimes it can be really obvious. Sometimes it's associated, for example, with a brain tumor or a large area. Maybe there's a stroke in the brain. So those are a little bit easier to see. But most often, especially in pediatrics, we're dealing with disorders that are very difficult to actually see on the MRI. So the most common thing that we treat is a condition called cortical dysplasia. And the MRIs can actually even look normal. They can look, abnormality can be very subtle. And that's why it's challenging. And also, it's really important to also know that you need a really experienced neuroradiologist to look at this MRI, right? So sometimes it can be so subtle that, and if you go to one hospital and they say it's normal, you may want to get a second opinion on that, because so there you go. So these, and then the other thing and you mentioned, in pediatrics, because the brain is still developing, there's periods where the MRI can be more revealing than not, right? So sometimes the MRI right after birth could be very helpful, but then, sort of closer to 1 year of age or so, the abnormalities may be masked until later on. So sometimes a repeat MRI may be helpful. Yeah. Yes?
This is kind of a difficult question.
Yeah.
We have a granddaughter that's had 2 surgeries and VNS and is still experiencing seizures. We understand is taking medication. Do you have any suggestions with regard to future diagnosis or what to do?
Okay, so the question is, your granddaughter's has had 2 previous surgeries. I'm assuming surgeries where they've removed a portion of the brain. Is that, or what kind of? Okay. Okay, and so parts of the brain have been removed, and there's other procedure, corpus callosotomy, where we disconnect the 2 halves of the brain. That can sometimes help differentiate where exactly the seizures are coming from, but it's also a treatment of its own to reduce seizures, and also vagal nerve stimulator. She's still having seizures. So very difficult for me to comment on specifics, because one of the things with epilepsy is every case is completely unique, right? So we'd have to kind of look at the details. But the fact that she's had 2 resections tells me that the team was somewhat confident as to which side of the brain it may have been coming from. So, when epilepsy surgery fails, it usually fails for 3 reasons. Number 1 is you can be in the right area of the brain, but not remove enough, right? So that we say the localization's correct, but the resection's insufficient. So we didn't remove enough. So that's one scenario. The second reason why it fails is you may be in the right area, you may resect enough, but the epilepsy changes. So, situations, give you an example is one, tuberous sclerosis, for example, is a condition where seizures may be coming from multiple tubers. You may remove one area, and then down the road, another area develops its own ability. And lastly is if you're completely in the wrong spot. That's another reason for it to fail, right? So, so for me to tell you which one of those scenarios, we'd have to kind of look at all the details. But one thing I'd encourage with, when we're dealing with epilepsy is to always, no matter where you start off from, is to kind of seek second opinions. And especially in situations where a previous surgery's failed, because that's a more challenging case to begin with, right? That's more, because they've already gone through that process once. So I would get multiple opinions. One of the things that once you start getting opinions about surgery, you'll notice in the epilepsy surgery world, not a lot of things are standardized. So different hospitals will do different types of tests. And they have different strategies to identify which part of the brain the seizures are coming from. And even that, there's different team strategies as to what is recommended. So really important, I always give the example, as a neurosurgeon, for example, we take out brain tumors. Brain tumors are easy because you can exactly see the abnormality and you go right there and you just remove it. And it looks so different from the rest of the brain. With epilepsy surgery, actually, as a surgeon, when you're looking at the brain, quite often you can't see the abnormality, right? So you're relying on a lot of tests that are done and prior. You're using EEG data during surgery, but none of those tests are perfect on their own. So there's no exact way to image epilepsy, and that's why the workup is is challenging, and that's why different teams may come at different conclusions once they look at that data. So I would encourage. I'm happy to take a look at it afterwards and let you know what I think if you have details, or we can always talk afterwards about them. Yeah. Yes. Yeah. Yeah, that's a great question. So quite often at our epilepsy meetings, we're looking at future technologies to try to better localize epilepsy. And, there's the standard things that you mentioned. MRI is pretty common, PET scan's common, MEG we mentioned earlier, SPECT we sometimes use. We do fMRIs. Some of the things that are more investigational that we're looking at, a couple things that we're starting to do at UCLA, Dr. Mathern's in the back there, we're looking at pH imaging as a role, for example, sodium type imaging. There's different types of vascular imaging, trying to look at the blood flow to different places of the brain during seizures. I must say a lot of these are sort of investigational at this point, so it takes time for us to be able to correlate this and to verify its utility in epilepsy surgery. But there's a certain percentage of epilepsy that the seizures are coming from multiple spots in the brain, and for those patients, curative surgery is not really an option. I'll come back to you. Yes, go ahead. Yeah. Yeah. Yeah.
If the VNS didn't work out, you're not an RNS candidate, you can't localize. Is deep brainstem next?
Yeah, so in terms of our palliative surgeries that we can do, vagal nerve stimulator, RNS in the situation where you have a good sense of where the seizures may be coming from, but DBS as well is another option similar to VNS. So it's sort of, deep brain stimulation is a technology that's been around for a really long time actually now, primarily developed to treat Parkinson's and tremors by targeting deep areas of the brain, specifically, and in epilepsy, specifically the thalamus. So the thalamus is sort of, think of it as a main highway of the brain, where a lot of important information leaves the brain, goes to the body, or comes from the body, to the thalamus, like the relay center. So a very important pivotal study was done that showed that DBS of a certain area in the thalamus is very effective at also reducing seizures. Now, something to keep in mind is they were effective in the patients that responded to VNS and also in patients that didn't respond to VNS. So actually, for the trial itself, they actually wanted the VNSs all completely turned off, just to make sure that it's a DBS effect. But sort of what the group's thinking is, even if VNS wasn't a good option, doesn't necessarily mean DBS won't be. It works through a different mechanism. So that's a good option to try. Right now, it's only approved in adults 18 years of age and older. And what it is electrodes that sit in the brain, connected to some wires that all go under the scalp, under the skin, and it sits in a little, connected to a little generator that sits under the collarbone, all under the skin. The other, go ahead.
So no localization necessary?
Correct. You don't need to. Now, there's different targets based on where you think, which networks in the brain are most active in the epilepsy. The most common target, the one that's FDA approved, is the anterior nucleus. And but we don't differentiate based on the type of epilepsy. If that makes sense. Yeah. Yes, go ahead.
Are surgical procedures most? When is that what you're looking for? Is it based on like length of time that you've tried trying different medications in that point, or just on the MRI that okay, we're
Right.
sure we know where it's from, so then surgery is an option?
Yeah, so the answer is different based on a different age group. In the really young, any uncontrolled epilepsy, so less than 1 or 2 years of age, is actually a reason for an immediate surgical referral. Because in the very, very young, these seizures actually will hurt their cognitive capacity. So it's a time-dependent problem. Those first few years are really, really important in life. So in those situations, if the child has ongoing seizures, they need to be referred right away. In the general population, or the other scenario is when there's a surgical syndrome. There's certain syndromes out there. Some of these are rare. Hemimegalencephaly, tuberous sclerosis complex, Sturge-Weber. Some of these well-known diagnoses where a lot of patients actually require surgery. They need to be referred earlier because we just know medications won't work. We'll still start with some medications, but we know they won't work. Other scenarios, we generally say when you failed at least 2 well-chosen medications. And medications that have failed because they don't work, not because you couldn't tolerate the side effects, right? One of the really important things, one of the first things that happens when you're referred to an epilepsy center is the neurologist is going to review everything. First make sure you have epilepsy, because sometimes that's one of the reasons why the meds don't work, because you don't have epilepsy. You're sort of being treated with medication. So that making sure the diagnosis is right, making sure you're on the appropriate medications, because different medications work differently in different scenarios. For example, infantile spasms have certain medications where they respond to better than standard anti-epileptic drugs. So generally, failure of 2 is what you need to get referred. Another question? Yes.
Real quick. So what is doctors consider a failure of medication? The reality is there are some cases where it's just going to be management, not necessarily cure. So people taking one drug and
Great question. So the question is, how do you decide what's a failure, right? Because sometimes if the medications are well controlling the epilepsy, and then you come off a medication, you have a seizure, is that a cure or not? So what we mean by well controlled, meaning there's no seizures. So, and if that can be achieved with medications alone, that's good. At that point, actually, we won't consider surgical treatment if the seizure is under control. Because even with surgery, even if we can achieve seizure freedom, it doesn't necessarily mean we can come off all medications. About half the time we can, about half the time we can't. So as long as the seizures are under control, we consider that well treated. Now, sometimes you're in situations where seizures are well controlled on a medication, but the side effects are just intolerable. The other thing we have to think about in children is the potential harmful effects of these anti-epileptics long term. Obviously, we know seizures are really bad for the brain, but a lot of these medications are meant to really slow down the brain. And a lot of families will come and tell us that they're really cognitively, their children are really impaired on some of these medications. So if your child is a candidate for surgical treatment, that's a really good option to pursue, because not only we can treat the seizures, but potentially sometimes even come off medications in the long term. Tell you a little bit more about epilepsy surgery. It's actually been around for a very long time. Been around for over 100 years. Actually, one of the most. It's really safe. A lot of hospitals now are doing these operations routinely, but at busy centers, it's really safe. In the past, and maybe still true today, but it's becoming even rarer. But in the really young, in the infants, less than a year, sometimes with really large operations, it's a little risky doing these operations. But really, in this day and age, it's really safe. So nothing, it is brain surgery. There's always risks with brain surgery, but at places that do this all the time, it's actually a really safe treatment option. Anything else? Another question? Go ahead. Yeah, go for it.
So if you have those electrodes in your brain because you are doing the DBS, is that pretty much the same as phase 2, but you're walking around, you're ambulatory with phase 2? You're recording maybe?
Different. So phase 2 is usually we don't want our patients walking around with phase. So phase 2, what we refer to as phase 2 is implanting electrodes in the brain to answer specific questions. One is, where are the seizures coming from? Second question may be, what do those regions of the brain do in terms of function? Sometimes we're trying to figure out, seizures are coming from one place versus another. So in those scenarios where we're implanting electrodes, we actually want that child or that adult or patient to actually be on camera, because we want to record seizures. That's a time where we may be lowering medications to try to figure out where the seizures are coming from. But we really want to capture that on video as well. When we're talking about deep brain stimulation, and these are long-term implanted electrodes. So these are electrodes that you go home with. They're going to, be in that region of the brain. We target them, put them in. We actually don't turn them on right away. We wait a few months, because there's actually a beneficial effect by just putting electrodes in. Because it causes think of it as micro trauma to that region. There's an electrode effect. Just by putting an electrode in that region, sometimes, usually it's not a long-term benefit, but at least for a few months, sometimes you can see benefit from it. So in those situations, we put the electrodes in, and we wait a few months, and then we ramp it up at that point in terms of the stimulation. Sometimes it can, but most of the time, when you go right into that spot, there's a microlesional effect. It's sort of similar to surgery where you are, in a way, injuring that area, right? Any other questions? How many people are, just by show of hands, considering surgery of any kind? Okay. How many people have had, or either yourself or the person you're here for, had surgery and it's failed? Okay. Okay. Yeah. So one of the important things with failed epilepsy surgery is to always, like we talked about before, just to reevaluate. Is this a situation where we, because there's a certain percentage of patients that have had previous surgery that we can still achieve a good outcome with further surgery. Obviously, the details are important, but always good to be reconsidered for that. Yes, go ahead.
I think it kind of depends too on what we define as successful.
Yeah.
If the goal is to, because mine improved my seizure frequency, but it didn't completely stop it. So when you're asked if it was a failure,
Yeah.
it kind of depends on
Yeah.
the definition.
So great question. So, great point, I should say. So when we're talking about the curative operations, what we define as success, what I define as success, is seizure freedom. But when we're talking about the palliative options, or there's situations where you may say, there's a lot of seizures that are coming from this one spot. There's this second spot as well, but we're not going to treat it. So that up front, you're not going to get a cure there. But you can get significant seizure reduction. So the palliative options, we generally classify success as 50% seizure reduction. Could also be a lowering of the severity of it, for example. But that's a good point. Yeah. When do we give up?
Of surgery, the pursuit of surgery.
Great question. Great question. So it's really important to have a very frank discussion, because there's certain patients that we will discuss, and that's another important point I wanted to make. These decisions, whether or not someone goes to surgery or not, should never be made by an individual physician. You need a whole team of neurologists, neurosurgeons, neuroradiologists, neuropsychologists, nursing staff. These decisions they're life-altering decisions. A lot of times they're irreversible, right? So that decision-making is really important. And the group needs to be very honest, because if they cannot achieve a good outcome, and in scenarios, I'll give you examples, when we really don't have a good idea where the seizures are coming from. If we don't have that, there's still VNS is still an option, DBS is still an option, but when we're talking about curative type procedures, those patients should not really be evaluated. If you don't even have a good hypothesis where the seizures are coming from, those patients should not even go on to these phase 2 studies, because those carry risks as well. There's a risk of infection, there's a risk of bleeding. This is brain surgery. And obviously, if you don't have a good hypothesis, there's a possibility that you're going to mislead yourself and go down a path which is not going to end up being successful, right? So I think that's sort of number one. And the second thing is you need to be realistic. In terms of, sometimes the seizures are coming from, I'll give you an example, right in the hand area, right? For someone that is, I don't know, maybe a writer. I don't know if you have writers still with all the typing that goes on, but let's say you're a writer, right? And that you're just not going to tolerate any operation in that area that may sacrifice that risk. That's another good scenario where you should not pursue invasive surgical options. Now, in this day and age, that equation's kind of changed a little bit, because now we have technologies like the RNS device where we can treat an area without leaving a permanent deficit in that region. So again, every case is going to be different, but there are several cases every year where we discuss at UCLA and the team says, we don't think this is a good scenario to pursue further surgical interventions. Yes. Yeah.
So if somebody was deemed to be like a pediatric adult, was deemed not to have any viable for surgery, would that be something where then you would use as they grow into their adolescence and as an adult? Is that something that usually progresses?
It depends on the scenario. You know, for example, generally, I'll give you a general example. Genetic type epilepsies in general, they don't do well with surgery because it's not generally not a focal problem. It's general. Those, you know, for certain individuals, they're just not going to be a candidate for epilepsy surgery. Other times, you know, one of the biggest clues as to the seizures may be focal or coming from one area of the brain is when the seizures look exactly the same every single time, and when they look like, you know, I'm, you know, simplifying here, but let's say one side of the body is always the side that moves first, right? We kind of know left brain connects to the right side of the body. Left brain controls the right side of the body. Right brain controls left side of the body. So if it's always my right side, that's where the seizure is starting from. That's a good clue that the seizures may be starting from the left side. So in those scenarios, if you have a consistent seizure type, generally no other genetic causes of epilepsy or metabolic causes, other causes, you know, there's many different causes to have seizures, especially when the EEG looks like it's coming from one hemisphere versus another or one location versus another. Those are scenarios where we would look for a surgical option, and sometimes if we can't find one, the neurologist may decide to repeat the test several years later. Sometimes there are situations where you do a workup initially, nothing really shows up, but then a subsequent workup may show a focus. So that can happen. And the other thing too, I didn't mention about, but when we do all these tests, it's really important if your child is a candidate for epilepsy surgery, it's important to do that surgery within a short time frame because epilepsy evolves, right? So if I may have been a good candidate for epilepsy surgery today, it doesn't mean that will always be the case. Because the more seizures the brain has, seizures beget seizures. So other areas of the brain that aren't used to having seizures can pick up their own ability to have seizures. So it's really important to if we're going to do a surgery, to do it based on current data, based on the current workup. Yes? Great question. So just to make sure I understand properly, you're saying it's really important that if we do surgery to make sure in a way we've removed all the abnormality so it doesn't spread? Is that a fair way of saying it? Yeah. Yes. At the same time, that's actually very challenging to do, right? So this is not the type of thing that the surgeon's going to come out of the operating room and say, you know, we got it all, you're cured, you don't need to see me, right? Because we're talking about, it's not generally an anatomical abnormal. It's not like I can define, you know, this area needs to be removed, and once I remove it, I can say, all right, you don't need to see me. It's an electrical abnormality of the brain. So it's hard to, so one of the things, even if we do a curative operation, is I'm going to tell the family that we need to see if this surgery will stand the test of time. The longer we go without their child having a seizure, the more confidently I can tell them that they're probably not going to have any more seizures. Generally, we think of it as 1 year from the time of surgery. Nowadays, there's many neurologists, many surgeons that would say you need 2 years seizure freedom until we can say, you know, you're don't like using the word cure, but you know, cured from your epilepsy. But there are cases that even if someone achieves seizure freedom, you know, 5-10 years down the road, the seizures may come back. Now, generally, when those seizures come back, they don't tend to be as severe. They don't tend to be as frequent, but it can be. So, yes.
Epilepsy is genetic. When his first EEG, they said, hey, we see some
Yeah.
epilepsy, and it started so late at 17. So is there a test to know that, or is she just
So there's known, so nowadays we can do gene panels where we can look at thousands and thousands of genes and look for, mutations in those genes. There's certain well-known genetic epilepsies. One of them tends to be one that commonly is drug resistant that we see is tuberous sclerosis, but there's a lot more that, and sometimes, just to get back at that word genetic, right? Genetic means any abnormality in the gene. Doesn't necessarily mean it's inherited, right? So you can inherit a gene mutation deficit, that there are certain one of those conditions, but also you can have a sporadic mutation. So when you're every cell in your body that's undergoing replication during that process can pick up a substitution or deletion of one of these gene points that can cause a genetic mutation. So it all depends. There's a large list of different genetic types of epilepsies, but that's something that you should discuss generally with your neurologist, and they would do a gene panel. Now, these gene panels are identifying a lot of genes that we sometimes don't even know what role they play. So we're sort of learning. We're kind of creating these databases and learning about some of the more rare types of genetic epilepsies. Yes?
Along those lines, are some of us diagnosed with cortical dysplasia in two areas on both sides, but also a genetic duplication. So would he still be considered for surgery if they already know there's a genetic component?
Yes, he can be. He can be. Yeah. Cortical dysplasia in general is something that we consider surgical, but I'm talking about generally where the MRI looks normal. There's no abnormality at all, and there's just a gene mutation. So we have done surgery in situations where the gene may be also affected. Yes.
What's your experience with long-term side effects, consequences of left temporal lobe?
Great question. So left temporal lobe. So the left temporal lobe is an important area of the brain, right? In the vast majority of right-handed individuals, their dominant hemisphere, which is the hemisphere that's responsible for understanding and generating speech, is on the left side of the brain. So that's why the relevance of the left side. But the temporal lobe has multiple areas of, we call it eloquence, but functional areas, mainly involved in naming, in ability to understand speech. Some say there's also some function to be able to generate speech, but most of that is really in the frontal lobe. Also, the visual pathways may be affected, which sort of, if I remove my left temporal lobe, I'm going to have trouble with my peripheral vision seeing things on the right upper hand of my world. Now, that visual defect generally is very well tolerated. That's the type of thing that we generally, if we were to do a formal test, we're going to pick it up. But in terms of patients coming and complaining that that's a problem in any way in their life, that's pretty rare. I actually haven't come across a patient who's had that. Now, the most important part of the left temporal lobe is the inside most part of it, which is the hippocampus, which is a structure that's really important for memory. And this is the most important memory. It's generally the verbal memory, which means this is factual memory, knowing what year it is, who the president is, where do I live, what's the name of my siblings, that sort of memory. So generally, a group should evaluate things really thoroughly before they recommend removing the left temporal lobe, and even the right temporal lobe, I should say that, because you want to make sure that the memory function is completely supported in the other half of the brain. Because, in the past, there's, famous case reports where they've removed both temporal lobes in situations where they've stopped the seizures, but, created, a really bad situation where a patient was not able to form any memories at all. So Now, the other thing to think about with epilepsy is that that temporal lobe may not be normal because long-standing seizures in that area of the brain may have pushed other brain functions out of that area. So it may not, in situations where the epilepsy is really bad in that area, sometimes there's not a lot of function there to be lost. But some of the testing that we can do can help predict if there's going to be any deficits in that area.
Do you find, like, so say someone had their left temporal lobe removed over the course of time, so they have some deficits, right away.
Yeah.
Over the course of years, do you find that those deficits get worse?
I don't think so. I think, we usually definitely do a pre-surgical neuropsychological evaluation where we look at a lot of those things, and then post-surgical. But then after, I'd say, it would be rare to find anything, many months out to years out. Yeah. Yes.
Besides VNS,
Yeah.
what kind of surgery, if any at all, could help with Dravet's, and what would how would the onset of puberty play?
Dravet syndrome?
Yes.
So in terms of the onset of puberty, that's a question for neurologists. I think, really generally those are not considered for a curative type operation, so that's why VNSs may be tried. Depending on the details, and other options, also corpus callosotomy, or, how old is it? 11, yeah. So deep brain stimulation sort of is maybe later in life if that's still epilepsy is a problem, but because that's approved 18 and over. There's not a lot of other surgical options, unfortunately. Yeah. Other questions? Anything else? Yes. 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 Okay.
Just give me some thought. Would she possibly be a good candidate for the DBS?
Yeah. 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 So the corpus callosotomy is a procedure meant to. It's like one of the palliative, in a way similar to VNS, where it lowers the seizure count, but it really prevents a certain type of epilepsy, the drop attacks, where you suddenly just fall, and these kids or adults, they may hurt themselves a lot by just suddenly dropping to the floor and hitting, sometimes hitting their head, getting orthopedic type injuries. So the corpus callosotomy just separates. It's a procedure where we don't really remove brain, but we go in between the two halves of the brain and disconnect them. And what that does is that it prevents seizures that start from one side to rapidly spread to the other side. So it helps lower generally the severity of these seizures. But yeah, having a corpus callosotomy does not prevent you from having a vagal nerve stimulator or a deep brain stimulator. And some of the data we're actually seeing is that these devices, or then the surgery, they work in different mechanisms. So sometimes the combination of them is sort of almost more than just the sum of its parts. So you can sometimes get really good control with multiple of these devices. Yeah. Yes. Yeah. Generally. Yeah.
But spreads, those that become secondary general. Is removing this area, that area,
Yeah.
generally seen as beneficial or complete sort of
Yeah.
scratch?
So different types of stroke. Are we talking about a stroke around the time of birth?
In utero,
Yeah.
any other type of brain.
Yeah. So the question is, if there's a stroke is basically damage to an area of the brain, either caused generally by hemorrhage, which means bleeding, or infarction, meaning not enough blood flow going to that part of the brain. Generally, when these happen in utero or around the time of birth, They tend to involve large parts of the brain. These patients generally may have some seizures, and they may respond for a while, but usually when they get older, it may not respond. So in general, if it's a large enough area of the brain, or that half of the brain, the best treatment for it is a hemispherectomy, which is a disconnection or removal of an entire half of the brain. And those kids actually do really, really well. Because of that injury has happened so early in life, that a lot of the important functions of the brain are actually carried on the other side of the brain. So those kids generally actually don't have a lot of deficit from surgery, and they can be cured. Now, yeah. So generally, it's the type of thing that we do surgery for in that age, from anywhere from like 5 to 10 to 12. Obviously, we wait for the seizures to not be under control, right? We wouldn't do it if the seizure.
Not under control, even if medicated.
If they're medicated and they're under control, we wouldn't do surgery. If they're medicated, still having seizures, that's when we do surgery.
After how many?
Generally after you fail 2. Yeah. Now, strokes are very common. You can get them any age in life, and if it's a smaller region of the brain, that can also cause epilepsy down the road. But we keep an eye on those. There's a lot of stroke that actually doesn't result in long-term epilepsy. But it's really important to do a full evaluation, because sometimes it is the area around where the injury to the brain is that's generating the seizures. So. Yeah.
On medication for a really long time, well controlled, right? So nobody really wants to mess with that balance. How do you know if they've moved beyond it, or
Great question.
like
Yeah.
they don't really repeat EEGs once they've diagnosed
Yeah.
whole event.
So,
On an MRI, they show like hemosiderin staining and
yeah.
things happening in the brain tissue inside that.
Yeah, so how do we know? So I guess in a way, correct me if I'm wrong, but your question is, if we're on meds and we're not having seizures, how do we know that the medications are still working, or the seizures have just stopped on their own? Is that what you're asking? Okay.
Like, do you stay on meds for the rest of your life, assuming that you need to?
Yeah, great question. Generally, the neurologists have a good answer for you, but I'll tell you from my perspective, it's really important, especially in children, especially at the age of 5, to have long-term follow-up, because children are growing. That medication dose that may be good for them today may not be sufficient when they're 10 years old, right? They need long-term follow-up, because especially in that scenario, because that is a known surgical syndrome. A lot of those kids, eventually the medications may not work. So it's really important to have good follow-up with the neurologist. They may consider doing EEGs to see how abnormal that half of the brain is, whether there's still things like spikes, slow waves. These are EEG terms, things that neurologists look at to tell you how excitable or how damaged that part of the brain is. One way to obviously find out if the seizures are doing anything is to come off the medications. But depending on what the EEG looks like, the neurologist may be hesitant to do that. So this is an area of medicine that doesn't have strict guidelines. It's pros and cons, right? If we have a 16-year-old, right, that I'm seeing that is wondering whether they can come off medication, but they're also looking to drive that year, we're probably not going to come off medications. Or at least if we're going to do that, say, all right, you make sure you don't drive until we come off and completely see, right? So, but that long-term follow-up is really important with the neurologist. And most neurologists will continue to follow. They're not going to say, call us when there's a problem. So. Yes. Other questions? No? Okay. My pleasure. All right. Happy to answer anything else.